All right, round two. We're gonna try to get this going again. For some reason, we were losing Eric there. So sent the invite again, and we're gonna try this one more time. We'll give it a second here. I just sent out the invite. I'll try one more time. See if he's gonna be able to join or not. Good old technical difficulties here on the Friday afternoon. Oh, let's try this here. What the heck is going on? Accept. Okay, not sure what happened, man. We lost you on that last one.
Am I unfrozen now?
Yeah, it seems to be glitching a little bit, but that's all right. We're gonna get rolling again. So we'll start from the top because I just started the other video of Eric going and not moving. So anyway, so today we're gonna talk about training clients and working with clients and keeping their knees healthy. And so many times in my career, I've had people come in and say I have bad knees, but there's no medical diagnosis. They haven't seen a medical professional. They're like, I just have bad knees. Well, that's like saying you've had bad food. It's really an opinion at that point, and we need to get to the bottom of it. Now, if you do have a pre-existing injury, yes, that's going to give us some great information on how we can attack your programming, etc. But we need to make sure that we're doing our due diligence to make sure we're making the right decisions when it comes to a programming point. Because if we don't know what the heck's going on and what you are currently capable of from a mobility and a stability standpoint, how can we design a program that's going to be optimal for you? So Eric, I'm going to pass the mic over to you at this point. So, give me some insight on, knee health in general and some of the considerations that you think about when it comes to designing a program with people with, we'll say knee issues for now.
Yeah. So the bad knee, it's like we have one, we talked about the shoulder, right? And bad shoulder. I got the rotor cuff, right? Everybody's got I got the knee. The knee equivalent. The knee equivalent of that would be, I got bone on bone, right? Not knowing what really that means. I got, a cartilage problem. I got arthritis. I got all those things. So we'll come back to that. But let's look at the fundamentals of what we're dealing with. We're dealing with a hinge, right? It's a hinge where you have your upper leg, you have your lower leg, and it does this, opens and closes. That's pretty much what it's supposed to do. It doesn't have a lot of play side to side, nor should it. And it doesn't have a lot of play rotationally. There's a minimal amount of give in there, but you have these straps that loop through. So imagine a strap from the front of your lower leg that goes through and then back attaches to the backside, right? Then you have, those are your ligaments. You have your ACL, your PCL, your lateral coligaments. All those things have that little bit of give to save you, but if you have enough force, nothing's saving you. So the key is, how do I get this to open and close, right? So I need to make sure that I have the freedom to do that. So first you look at the muscles immediately surrounding that. We have the calf complex, we'll cross over that. You have the quads where the tendon of your knee, right in the front of the knee, if you feel the front of your knee, that little triangle there, that's the tendon of your quad muscle, right? And then you have your hamstrings that cross over there. So obviously we need to make sure that we have good tissue quality and good mobility and all those tissues immediately surrounding that, because if not, it's going to create pull where it's going to change the dynamics of this. You also have this kneecap, this patella that sits on the front, right? That kind of floats there. And if you don't have good muscular balance in there, that can create some tension on there. So a lot of times that's a matter of just making sure that you have good tissue quality and flexibility within the tissues around that joint, right? So that's the first thing. Then we look at, okay, well, the scariest thing, and I had a post about this yesterday, is when I hear about one of those CLs, right? The MCL, LCL, PCL, ACL. So kind of, we'll go through those real quick and talk about, all right, well, your PCL, usually when you get that, that's when there's an impact where you land directly on your knee. So like I have with football players when they'll dive for something, or you'll see it probably in soccer as well, or probably a lot in MMA, I would imagine, where you land directly on your knee. You also see it with car accidents where your knee hits into the dash. That's where you see a PCL. Generally, they don't do surgical interventions with that. It's just time. And they won't do much with that. Same thing with the lateral and medial ligaments. They'll get some laxity within there. but they generally, unless it's a significant thing, or you're an athlete, has to get back on the field, they're not going to do a surgical intervention with that. Your ACL is another story. And the ACL, where you're getting that is if your knee's supposed to hinge. Well, now when you buckle, if your foot collapses, that valgus collapsing of your foot, and then your knee goes here, is one of the big issues we get with ACLs, because about 70 or 80% of your ACLs are non-contact. All right. There are situations where, boom, a helmet goes into your knee. You know, you can't do, you get kick slide, or in the case of your MMA guys, you get, you know, kicked in the knee. That's not a whole lot we could do about. But that non-contact thing, and there's actually some good data that just came out. It actually won some kind of a research award as far as looking at the compression as well. That compression and then inability to fall, that it causes you to look in other planes for movement because you can't get that. So we'll go back and kind of, you know, look at some of those mechanisms in a minute. But the big key there is how well you manage impact in control. And so the good news is to all of this, it sounds all scary, but the good news is that there's really good research also that shows that injury prevention programs done well that focus on deceleration and body control have been able to reduce injuries pretty significantly in non-contact ACL. So tell me what that means, since you see it in two worlds. You see it in MMA, and then obviously you have a strong soccer background, and those are two areas where you see a lot of ACL injuries.
Yeah, so I'm gonna actually start with the MMA world, because there's sort of two mechanisms there. One is pretty abnormal for most athletes, but I don't want to say it's a little bit more normal for grapplers, but that's the LCL injuries. Now, lateral collateral ligament, which is on the outside of the knee, and if you were to basically take your right heel and if you take your right heel and place it on your left knee and into that figure four position, and you actually palpate the outside of the knee, there's this little ligament. It's about the width of a pencil, and that's your lateral collateral ligament. And that is, you know, one of those injuries that's one of those ligaments that in general, we don't see a lot of LCL injuries unless it's traumatic. LCLs don't tend to go. But in the world of grappling and heel hooks and leg locks, essentially when you're doing any type of leg lock or any type of submission, specifically that like a heel hook or variations of that, inside outside heel hooks, really what people are trying to do is they're trying to stabilize the hip, and they're trying to stabilize the ankle, and trying to get the knee to rotate. And essentially that's what you're trying to do. And quite often the injuries that happen because of that is, one, it is an LCL. And if we're going to have to choose what ligament between the ACL and the LCL, which one has to go, I'm going to pick the LCL every single time, because those tend to heal much faster. And a lot of the times, you know, you don't have to do surgery, because they can actually heal quite well on their own. If they're about a grade 2 to 3, you're looking at surgery. But I just had one of my clients come off of a grade 2 grade 2 LCL tear, and it was simply he was working with someone, and that individual moved a certain way and manipulated the knee a certain way, and pop, there goes the LCL, right? And he had a strain, and he's almost back to full strength now, but it took about 2 to 3 months of physical therapy and a quality strength and conditioning program. So that's kind of the first one. And the same thing when it comes to the ACL. Most of the times when you see an ACL go in the world of mixed martial arts is, one, again, a heel hook. And the whole point of a heel hook is to do what Eric kind of said earlier. It's when that sort of foot goes inward, and the mechanism of injury is towards that valgus position. And that is essentially a heel hook, right? So it's the hip stays in one position, the ankle stays in one position, and then, you know, the opponent's going to try to basically tear your ACL, and hopefully you tap rather quickly. So in the world of mixed martial arts, that's when we tend to see that. The other time that we see it is, and if you're familiar with jiu-jitsu, this is going to make sense to you. If you're not, it's when people jump guard. And what jumping guard is, when you basically jump, you wrap your legs around your opponent. And if they're not expecting that and their feet are not in a good position, you'll see people will go down, and a lot of the times they have that traumatic ACL injury. So that tends to happen there. And now let's talk about the ACL with soccer players, right? Because that is, you don't even want to say ACL around soccer players, especially female soccer players, because it's one of those things that it happens so much. And there are several considerations that we need to talk about when it comes to that prevention. But, you know, the one thing we need to really understand, the main anatomical differences between males and females is the Q angle, which is the angle of the hips. And in general, women tend to have wider hips than men. So men tend to be a little bit more stacked vertically. So if this is the femur and then this is the knee and then down is the ankle, men tend to be a little bit more stacked into that sort of vertical upright position, whereas females tend to be more towards that V position because the hips are wider. And that actually predisposes them to potentially being in an unadvantageous position for the ACL. Now, I'm not saying because the ladies have a wider Q angle that they're going to blow their ACLs out. But again, it's just from a pure anatomical position, it's not advantageous. But one of the things that we see from a non-contact related standpoint when it comes to ACLs, it's just the inability to land and absorb force with good biomechanics. That's one. So just basically learning how to land and decelerate. And the other one is being able to cut at a high rate of speed. And if you don't have the strength and the ability to decelerate and the movement quality to get in and out of those positions, you're going to potentially end up with a non-contact ACL injury. And those are usually when it happens. Are there other times where someone's going to come in and slide tackle? Absolutely. Those things happen. But what we are trying to do as strength and conditioning coaches and health professionals here is try to give our clients the best scenario possible so they don't have non-contact ACL injuries, right? And that comes through quality screening, a quality evaluation. And I'm going to tell you right now, it's all about the programming and how you execute that program, because when you have, whether it's a return to play protocol or just a really, really good protocol, Mike Boyle says this all the time. A good one of the best ways to prevent ACL injuries is just have a quality training program. So there are several mechanisms of injuries that we could discuss, but those are the two big ones when it comes to, again, the athletes that I work with, a lot of soccer players and a lot of fighters and grapplers.
Okay, so there's three things that you kind of put in there that I want to pick up on. One, I'll just pick up where the sports that I work with a lot. When you see with baseball and softball, you'll see knee issues, not as much with pitchers. You'll see it more with hitters, but there is an explosive rotation of the pelvis, and you have cleats on, and if that cleat is stuck in the ground, and now the knee is caught in the crossfire of the two. So one of the big keys is to have ankle mobility, but not just dorsiflexion. We'll talk about that in a minute, but we need to also be able to have some play right to left and side to side in the ankle. And then you need to have good hip rotation. So if you're a golfer and your knees are aching after taking a bunch of swings, it's usually because you're not getting enough rotation at the hip. And now it's looking for it, and it's going to go either up or down. So it's going to go into your low back, or it's going to go into your knee. So the next thing is you mentioned about female athletes and how they are more predisposed. Statistics show about 1 in 4 high-level female athletes will have a significant knee injury. I saw that when I worked with women's professional softball as a strength coach for the New Jersey Juggernaut, which was the New York team in New York, New Jersey Juggernaut, which is our pro team in our area. And we had 12 girls on the roster, and 4 of them had had major knee surgery. I'm sorry, 16 girls on the roster, 4 had at least 1 major knee surgery, right? So the stats hold up. That doesn't mean that you're going to, like Mike said, it's not a death sentence. And there's a lot of factors that need to be considered. There's hormonal factors in there, what happens in your ligaments when different times of the month hormonally. There is the Q angle factor, but the biggest factor is that female athletes get treated like shit, quite frankly, is that their training programs really suck. And we baby female athletes, so we don't get aggressive enough with them, unfortunately, is what I've seen in the strength and conditioning world. And so we don't address not only their unique needs, but we don't even address their needs in terms of just getting them strong and stable enough. So that's one of the biggest flaws I see where you have that higher increase there. Now, you also talked about, and I brought it up, is that the knee is caught in the crossfire between the foot and ankle and the hip. And I had a post earlier this week talking about the communication between the two. So if you have your foot, that arch in your foot sets everything in your lower leg in place. So as soon as that arch collapses, well, then that whole lower leg internally rotates, and that creates that valgus force. And then the knee either does this or does this. So we need to be able to get that foot set into a good arch position. Doesn't mean it stays there all the time, but your arch, I always tell people, your arch, when we decelerate, acts like a parachute, right? So it decelerates and it softens that landing. When you accelerate, it acts as a spring. It's one of our springs. And so if you don't have that and your foot just pancakes onto the ground, well, it's going to take everything on top of it with it, right? So the ankle is important. And then there's another post I put up about considering the ankle, is that it has to have that play that I talked about side to side. It has to have that play right to left. And if it doesn't, it's going to find that range in a joint, the next joint up, which doesn't have side-to-side or rotational play. So why is this important? Well, I deal with field athletes who get their ankles taped, right? And so I've always had this conversation, and I remember having this conversation with one athlete. It's like, yeah, my ankle was bothering me, so I went to the trainer, taped my ankle. My ankle feels great. Now my knee's killing me. And if I have to pick between the two, I'd much rather have you roll out your ankle than blow out your knee. So my basic rule of thumb is if you're going to get your ankles taped, maybe the team makes you do it, or you do it for style or support. Here's the thing. Draw the alphabet with your foot. If you can't draw the alphabet with your foot, you don't have that freedom of motion. So just tell your trainer, ooh, too tight, and they'll back off so you can get that range. Now, at the other end of that thing, that's your hip, right? And the main steering of your hip is your glute, but there's a bunch of other muscles that are involved in that control rotation and create extension and flexion. So we have to consider those, and having those communicate to steer the knee. And the knee is just the innocent victim kind of caught in the middle, right? So if we're putting together progression of drills for, say, someone comes in, first we have to figure out, as you said with the evaluation, is it what's our issue here, right? And if we just go through our checklist, kind of go through the checklist you go through as part of your assessment in terms of looking to see if someone says I have an issue, all right, we're going to be detective now. Let's see if this is a mobility issue, stability issue, that kind of thing. Kind of go through your thought process and checklist.
Just from the starting point where I actually run people through the full evaluation.
Yeah, so we've already got all their key questions done. We've done all that stuff. All right, now cool. It's all right. What am I actually going to test here to see what the problem is?
Well, I mean, Eric and I met through FMS, so I start everybody off with an FMS, and that's just something that I always do. And now, all of those patterns within the FMS can absolutely have an impact on lower extremities. But so we're going to run people through the FMS, and we're going to see, first of all, whether that person is a little bit more biased towards needing mobility or stability. And I would say with female athletes, and again, the trend tends to be female athletes and ACLs, we tend to see a lot more deficiencies in stability, motor control, and core function in general. If I were to evaluate 10 female athletes, I would be willing to guess the majority of them are going to need, a little bit stronger core, improved core function, and from a lower extremity standpoint, just nailing all those patterns. So we need to look at where they need to go even from a programming standpoint, because that's going to give us, again, more information. And then what I do is I'm going to break it down. I'm actually going to go and I look at, I'm going to have them take their shoes off. I'm going to look at their foot strike when they're walking. I'm going to look at their foot strike when they're jogging. I'm actually going to assess tibial rotation because that's actually going to play a role in knee health as well. I'll get them on the table and do some basic table assessments, right? I'm going to do supine internal external hip rotation, probably do a Thomas test, modified Thomas test, just to get some more data on what's going on in that lower extremity. And then I'm going to step back and obviously look at their regular posture as well, and then run them through motor control screen, and then go from there. And then at that point, if I need to dig a little bit deeper, I'll actually put them in scenarios where I have to watch them decelerate at a little bit higher rate of speed. And I'm not talking max effort, but we know as strength and conditioning coaches, if you've worked with anybody, speed can be actually another form of compensation. So if you can see someone do something really slow, cool, that's awesome. But when you start to add power and you start to add a little bit of speed into the scenario, and you have to integrate that in a very, very smart fashion, you're going to start to see things a little bit differently. So from an assessment standpoint, we need to see how well they can actually absorb force and change direction and be on one leg, be in a split stance, be in a bilateral stance. And I run the gamut on all of that, and then we start to design their program.
So yeah, a couple things that I would kind of piggyback on that is, one, for people who kind of maybe did FMS early on, or they haven't been around it in the last couple of years, one of the things that was added into the screen because we found so much value to it is measuring ankle active, closed chain active dorsiflexion at the ankle. And that is something I do. And not only will I do just the eyeball test that we do, the FMS, I'll actually get out a very cool tool on your iPhone is the Measure app. And it becomes a little goniometer. You just put it right on the front of the tibia, and we want to get about 40 degrees. And it's not exact because everybody's tibia, height is a little bit different in terms of the relationship with the foot length. But if you're grossly different, if you're at 20, well, we know that that's a big thing. Now, if you go to land and you don't have that give where there needs to be some translation of the knee forward, and it can't go because you don't have that dorsiflexion. Well, all that force is now going to go up into the knee, and it's going to be looking for that range there. So the active dorsiflexion is one big one. The inline lunge of all the tests, and I know John Tureen, who's a good friend, when he was with the Colts, you had to get a 3 in your inline lunge before you went back on the field if you were coming back from a lower body injury. And so, because there's so much deceleration involved, especially with a skill athlete, that we have to look at. So that kind of correlates with that. And then that lower body motor control screen is very similar. It's actually a derivative of the Y balance test, which is incredibly impactful for that person who may be able to escape through an FMS because they're maybe a little on the hypermobile side, but we catch them on that motor control screen. So let's say if they go to slide out, it's a single leg reach. It's actually a derivative of the STAR excursion test that Gary Gray came up with. And if you can't do a single leg reach while balancing on the other foot to at least double your foot length, that's a pretty good sign that you don't have great motor control. Now imagine, I had a guy in about a month or so ago who's a runner, and he crushes the FMS, but his motor control was awful. And so now if you think about that, you got 4 times body weight going through that knee every time he lands, and he goes out and runs a 5-miler. Every time he's getting that impact going a little bit more, in not the right direction. So now let's kind of go to the impact thing. So in the progressions, like I know I put up some deceleration drills in some of our videos last night. First thing I'll work on, and I, we'll probably do a whole talk on this, is I have this, what I call Power of 3 system that I use to kind of develop field speed and so forth. And I always say, there's 3 phases of movement. There's deceleration, acceleration, and that changeover, right? Basically that amortization going from one to the other. Then there's 3 directions we move: front, back, side to side, and rotation. And then there's also the 3 foot positions we could be in. We could be in a single leg, like when we're sprinting 85% of the times on a single leg, or we're cutting is a single leg. Breaking down, changing directions in a split stance, like a lunge type position. That's why that's so important. And then an open stance, which we don't spend a whole lot of time in. So I kind of break it down progressively like that. And I'll start single leg deceleration, because that's usually where you see most of your stuff happen. And start with some basic hop outs where you just hop from one foot to the other and be able to decelerate and stick. And my cue is from the time your foot hits the ground to the time you own that athletic stance, you need to make that as short as possible, because the longer it takes for that to stabilize when real life happens out there, whether it's stepping off a curb or whether it's cutting and changing direction, the longer that takes, the longer it takes for you to self-organize, the more of a problem we have here. So that's usually where I'll start. And then obviously we can do a bunch of stuff, jumping off the boxes and decelerating, but you got to be careful in terms of your progressions, because I'm sure stories. There's a legendary story of a well-known speaker at a fitness conference who tried to stand on a stability ball in front of the group and blew out his ACL in front of the group. So you need to be cautious. You can't just say, hey, I saw this cool drill on Twitter that somebody was doing, and it was jumping off the box, and he said it was good for ACL prevention. Well, that's a long way down the road. You're pretty deep into the movie before that. We need to kind of back that off. So I'll usually start with single leg deceleration first, and then we can go into a little more aggressive heights, a little more aggressive with our foot positioning, and then we can go into some bounding and that kind of stuff. Any other tips you have in terms of your progressions?
No, I think progressions are important, and I think that's the reason why you need to work with someone that knows what they're doing. Because if you just start Googling or searching for exercises for ACL prevention, you're going to get a bunch of stuff, right? So progressions are important, and that's just part of being a good coach, is knowing, hey, listen, we're going to go from here, we're going to go from here, we're going to go from here. And I would say when you get into deceleration, it's not as cut and dry as, okay, we're going to do a body weight squat, and then we're going to do a light goblet squat, and then we're going to do a double kettlebell front squat, or et cetera, right? It's in the weight room, I would say progressions are a little bit easier to manage, but when you're working on true deceleration training for athletes that need to cut, change directions, and go, you have to go super basic, and then don't add too much variety early on, because then you're just going to be bouncing around doing a bunch of stuff that doesn't really move the needle when it comes to a deceleration component. But there's one other thing too that I would absolutely add when you are teaching the athlete how to move at the beginning. the walking lunge, a lot of people will use a walking lunge as part of their warm-up, and there's nothing wrong with the walking lunge. But just like the inline lunge in the FMS, the walking lunge is the first sort of introduction to decelerating your body in split stance. And within the inline lunge, we have to decelerate on one leg and we have to decelerate on the other leg. So that will give us a great information. You talked about John Tureen. It also gives you great information on overall, like you said, closed chain ankle function, but at the same time, relative internal hip rotation and relative hip extension, right? All of these things play a role, but when people think deceleration, they think I need to go from fast to slow. And sometimes it's just going from slow to slow. And that's actually one of the ways to really think about deceleration training in general. It's not about hammering the gas pedal as hard as you freaking can and then trying to stop on a dime. That's like the last thing that you do. Like, there's a reason why in gym classes they have pads all over the walls. It's not because they're trying to do deceleration training. It's kids can't slow down, right? And that'll take me to another part that we can just quickly talk about, Eric, and I know we're going to agree on this, is it's really cool to have a fast athlete, just like it's cool to have a fast car. And everybody thinks about speed. Everybody thinks about linear speed and how fast you can get from point A to point B. But guys, I'm going to tell you right now, none of that shit matters if you can't slow down. Okay? None of it matters. So if you are going to spend X amount of time building speed, I need you to spend almost double that time building the brakes. Because it doesn't matter how fast you go if you can't slow down. You're just going to start banging into shit. Okay? So you have to take a quality approach to training people in general. And I would argue that, most athletes, their ability to get in and out of positions and own multi-directional movement and change of direction, depending on the sport, that skill is going to be way more impactful within the sport than just seeing how fast you can run a 60.
Yeah. And the first place we always start is awareness, right? So most people, if you just stand there and you're the coach and you say, don't let your knee go in, that's happening at a reflexive level. They have no idea what you're talking about. You might as well be talking in another language. So
don't do that. Yeah, that's like saying don't do that.
Yes, it's as simple as the biggest thing that I do to introduce it in a basic level is I'm going to have you stand in a single leg stance, right? Just an athletic stance, so you can't lock your knee and hang on that, so you can't lock your hip and hang on that. Just sit back a little bit. I always say that athletic stance is a position you can sprint anywhere out of, right? So getting that little bit of athletic stance. And I'm just going to take your knee. I'm just going to poke right, poke left, pull front and back. And I'm just going to do a little bit of perturbation for about 30 seconds, right? And I'm just going to create that awareness. And at first, you're going to be like a drunken sailor all over the place. But then you're going to start to learn to react and self-organize. And then you start to learn, okay, well, if I grab the ground a little bit better with my foot, if I sit into my hip the right way, if I can redistribute, that's kind of the key to keeping me from allowing me to, because I'm trying to poke you out of position, and then you have to figure it out, right? And just kind of work through that. Now, when we talk about, all right, is there bad exercises for your knee? And you say lunges, lunges hurt your knees. Well, no, lunges with bad distribution hurt your knees. And bad distribution means you're not distributing the weight across properly. It's not that your knees are going over your toes. Like, knees over your toes is not a bad thing. We wouldn't be able to do anything in life. There's a guy who's making a living right now just telling you how good it is to bring your knees over your toes, right? That's it. It's not
Great
a bad
name,
thing.
too.
Yes.
Great name, knees over toes guy. I mean, hey,
yeah.
I don't know whose marketing company is, but they did all right.
He's picked his lane and he's flying in it. Kudos to him.
Man, he's killing it.
So like, and squats aren't bad for your knees, right? Just because squats hurt your knee, okay, first of all, if it only hurts one knee, then it's not a squat problem, right? It's a knee problem, okay? And people don't understand, and then they'll say, well, I just won't squat as deep. Well, you don't understand that as you actually squat deeper, the surface area in contact with the patella actually gets larger. It's actually safer to be there. Now, that's obviously relative to load and competency and capacity, but we need to go through those ranges. Now, I mentioned this earlier. I'm going to come back to it. We talk about joint health and the cartilage and the bone on bone and all that stuff. Well, if this is the top of your lower leg and this is the top of your upper leg, and we have this, on this surface and on this surface is your cartilage, right? That cartilage is a spongy cartilage. And what happens is it gets its nutrition, okay? So people say, oh, I'm going to go take glucosamine or I'm going to drink milk for for my joint health. Well, the only way those nutrients get in there is through a process called imbibition. So when you create force into them and compression and opening and closing and moving through full ranges, it squishes that sponge, and then that sponge will soak up those nutrients, and we need to be doing that. So arthritis is really, and those cartilage issues are at first, they're a nutrition issue, but not because you're not taking enough calcium pills. It's because you're not getting through full range. Now, if you start to shorten your range all the time, well, now you get less and less movement through there. And then what's going to happen is those areas that don't ever get touched and moved, they start to calcify. And now you get that grinding and all that kind of crap that's going to happen in there. So, you know, we need to move through full ranges, but you have to do it within the capacity, movement competency of the individual that you're working with. So don't automatically assume that something is bad for your knee. If you can't squat, well, that's a squat problem. And so inherently we need to be able to do those things, right? We need to be able to lower ourselves to the ground. Like, you know, I joke when we talk about, you know, who's been told that they should never do lunges again. Okay, well, I got a situation for you. You're a mom, you're coming home from the grocery store, you got a grocery bag in one hand and a toddler in the other, and you dropped your keys at the front door. Now what? Right? Am I just going to stand here until someone else comes home? No, I got to lunge down and get the keys, right? So we need to be able to do these things. It's just relative to what it is. The other factor, and we talk about, is sometimes it's about what you stop doing to it, right? So if lunges hurt, we'll stop doing lunges first until we can figure out why you can't lunge. The other thing is and so there could be corrective things we do, ankle mobility, all those things. It's what you do to it. Sometimes what you stop doing to it, right? Is sometimes you're creating some stiffness around your knee because of the activities you're doing, and certain things are going to have more propensity to do that. So with the rise, you know, I've seen a lot of it, and I don't know if you've seen this, with the rise in popularity of Peloton, right? You know, there's a whole group of people on Twitter that train in our field that are hating on Peloton. It's the dumbest thing I've ever seen. If people are exercising, I don't give a shit what they're doing to do it, right? If they have pogo sticks at home, good, right? Anything's better than sitting on the couch. We have a health crisis going on right now. We need to get people moving. So if they're going to use it, it's people who would never do cardio before now like doing the Peloton. Awesome. But understand that cycling, being strapped in and fixed into that bike, especially if you don't have it set right, that's going to put a lot of work through the quads. And even if you have it set perfectly, your quads are going to get fatigued. They may stiffen up a little bit. That little bit of stiffening may cause a little bit of yanking at your knee. Is it the end of the world? No, I can do a couch stretch and undo and get a foam roller on my quads, and I can do 90% of that, right? But you need to consider that, because if you accumulate that over 2 years of doing Peloton, and I've never done any quad stretching or quad mobility, you could start to have some knee stuff poke up, right? So what you're doing to it. So in terms of looking at stuff, looking at the volume of what we program, we need to consider that also, what could, you know, creep into your knees.
Yeah, absolutely. So two things I want to talk about. So one, you know, people saying, you know, squats are bad for your knees. I would actually argue that not squatting is worse for your knees than squatting. Actually, I know I'm correct. Not going into a deep squat or a deep knee bend. Now, there is a difference, by the way, right? Taking the knee through a range of motion in a squat, we think of squat. We think when most people think of squat, they think gym squat, right? They don't think of lowering their center of gravity to do a task. And that's something that we talk about all the time. Squatting is an essential human movement, but it's also an exercise. But they're different, right? One can be with body weight and external load, etc. The other one may be just something that you're doing in your daily task. But we need to be able to bend both knees in a bilateral fashion. And I would argue if you do not do that on a daily basis, taking that joint, your knee joint, through a full range of motion, that's when you're going to start to have issues. I was just listening to Andy Galpin on the Huberman Lab podcast, and I love listening to those guys because they're just awesome. But, you know, he said one thing that I love that he said, and it was super simple. Dr. Galpin said, take each joint through its full range of motion at least once a week. That is some of the best advice that I could give someone. Is just to get those knees through a full range of motion. So you've got to use it or you're going to lose it. And Eric talked quickly. We did a post about this on synovial fluid. And if you're not familiar with synovial fluid, it's like WD-40, man. It's lubrication. And like he said, you've got this cartilage, and in there, we've got a membrane, the synovial membrane. And at rest, the cartilage will soak up the synovial fluid. And the only way to get that release is by using it. So literally, the only way synovial fluid is going to get released and produced is by squatting and using the knees. So when you don't use it, you lose it, and that's going to create even more issues. It's like that old rusty bike that's been sitting out in the rain. You can't just expect to drive that thing without doing a little bit of maintenance. And it's the same thing with the knees. I've had more success reteaching people how to squat through a series of progressions and fixing their knees, whatever the hell you want to call that is, but improving their knee function just by regaining their deep squat. It hasn't been a bunch of clamshells, a bunch of TKEs, and a bunch of cool little exercises. It's just getting them to dial in that pattern. And that's the most success I've had. And every single client that has actually been through that process with me, they're like, I thought squatting was bad. And I'm like, no, not squatting is bad.
Yeah, no, I'm with you there. And then the last piece I guess we could touch on is when we talk about the knee, you know, for the average fitness person, especially, you know, pre CrossFit and M45 and all the other stuff that's out there now, is most of, you know, you went to a gym. So what do I do for my knees? I did knee extensions and maybe I did hamstring curls, right? These machine-based single access things. So are those bad? Were we wrong? No, they're not bad inherently. There's a piece of that needs to be in there. It just depends on where you are in the continuum. Understand that it's value is that you could have somebody that doesn't have the ability to be weight bearing. You can have someone who doesn't have the ability to at least generate enough force to stabilize the knee, and that's where they could have their place. Where the shortfall is, and you mentioned, you know, unfortunately the kind of typical shake and bake PT you get when you go for your knee is I'm going to get TKEs, these terminal knee extensions. I'm going to get, you know, maybe I'll do a standing TKE with a light rubber band, right? Maybe I'll get some knee extensions and some hamstring curls, and that's it. Like, it doesn't pick up where you need to be able to actually control that thing in space and create that communication between the foot and the hip. And so that's where things get lost and say, oh, well, so what's the path that people go through? Is they go to the doctor, say my knee hurts, right? So what are they going to do? First option is physical therapy. Then your physical therapy, I did a bunch of clamshells, TKEs, never anything weight bearing other than maybe a really super light TheraBand, you know, standing knee extension. And now my knee feels a little better when I leave the clinic, but like as soon as I go to do anything, it hurts again. And so now you go back to the doctor and say, well, you're going to need to repair that. Now, the reality is that, you know, if you took MRIs on most adults' knees, you're going to find some sort of, you know, something that you could be repaired. I know I went, you know, going back, I think I went to, because I was having some issues in my one knee, and it seemed like symptomatic of what would be a meniscal tear, and had an MRI done it, and he said, I think it's meniscus based on his manual test. Then came back, called me and said, hey, listen, you have a unique thing, something you generally don't want to hear when the doctor calls you. But yeah. He goes, where you have that medial lining of your knee is torn, and repair that knee. He said, so rather than having typical meniscus is like a tooth pull, like, you know, I know people that have been squatting 2 weeks later after getting a meniscal surgery. He's like, well, you'd have to be off your feet for about 5 weeks. So I said, okay, can I call you back? And he said, yeah, sure. That was 15 years ago. And since then, I've done a lot of deep squats, jumped on boxes, sprinted, dragged sleds, done anything you can imagine. And my knee doesn't hurt. My knee hurts more to your point, Mike, when I don't exercise. My knee could hurt if I sit on the couch wrong, right? Because if you have a meniscal tear, depending on how you have that, there's bucket, you know, handle tears, and there's different types of tears in there. But it's almost like, the best way to describe it to me is like having a hangnail, right? And you go to put on a glove. You can put on that glove 9 times out of 10 and it doesn't bug you. And then at one time it catches, it bugs you. And that's with me. Like if I sit on the couch wrong, it could bug me, but then I can do everything else I need to do. So then it's a matter of weighing out costs and benefits of, do I really need to go and get surgery? I mean, there's people living right now who don't even have ACLs and can live a happy life. It's a matter of what environment you're going, you know, we talk about in the course, like what environment do I need to send you back out to? And is it really worth what we're going to do? And then if you take the vast majority of the non-exercising population and you put them into surgical intervention, into a rehab setting, are they going to just continue the downward spiral of dysfunction and get a little more and more sedentary? And yeah, they got that little bit of relief in their knee, but now that's a cascade of other issues that have come out of this, right?
Yeah, absolutely. And you know, one of the things too about when we're talking about the knee, We can talk about the knee in itself, but like Eric said, it's a hinge joint. And it's really only supposed to do this, flexion and extension, right? That's what the knee does. But the problem is like anything, it doesn't live in its own silo, right? So that's why we're always talking about ankle mobility and hip function and even core function, because it all plays a huge role in it. So anything else we want to cover before we wrap it up? And we can obviously tell people, people about what's going on, etc.
No, I mean, the reality is there's medical symposiums on the knee that go a whole weekend, and we can go deep into all the different things of different types of not only medical interventions and the follow-ups after that, but also in terms of functional progressions and those sorts of things. But I guess the biggest thing is, I mentioned it, up front, that I got the truck loaded, ready to go. I'm heading down to Cherry Hill, New Jersey, which is just outside of Philly. We got a big weekend this weekend. I have tomorrow teaching an FMS level 1. It's going to be live. We haven't had a whole lot of live FMS courses since COVID, so I'm excited about that, to get in front of people. And then Saturday night, my friend comes down from Massachusetts, and we have a big day. We have our first, lights on, live Principles of Program Design course. 8 hours of, interactive fun that we're going to go through everything from, why are we doing this, and kind of breaking down our silos and some of our predispositions and thought processes with training, all the way through initial client intake and a lot of different fun interactive stuff we do with that, to what assessments we're doing, why we do those assessments, how they come into play with our program design, and then actually how to write programs. And we're going to have live case studies, people submitting case studies that they want to have broken down to their clients. And then once we get through all that, then we talk about, well, how do we adjust this program based on readiness and recovery and all those things. So it's going to be a full day. If you can't make it down, you can take our online course, which is online. And if you're not sure if you're ready for the online course, we have a free preview, right? We took the best snippets out of the online course and chopped it down to about 15-20 minutes, where you can get a little taste of the kind of stuff we're working on. So check it out. It's all on principlesofprogramdesign.com. If you haven't been following the format of how we work things, the way it works is we do content throughout the week leading up to a specific subject. And like this week, obviously, is the knee. And we have posts all week about that Mike and I put up. And then we do a Friday Live. The Friday Live is going to be coming out as a big change coming up. We will announce that hopefully next week, as far as where we're going to take this to the next level. But that's some exciting stuff to come as well. Did I forget anything?
No, not at all. I mean, guys, listen up. Check out principlesofprogramdesign.com. You can go and search for that online course as well. Like Eric said, we've got about an almost 20-minute video that's going to give you a lot of the information that we're going to cover. And guys, in the live course, we're going to teach you this is not about templates. This is not like insert squat here, insert split squat here. We want you to think about why you're programming, because let's be honest. If I ask you why is X in your program and you don't have an answer for me, then it shouldn't be in that program to begin with, right? So we're going to teach you the why. We're not just going to give you templates on programming. You can get those damn things any way you want. We're going to arm you with the education and the information so you can make better decisions. And that's what it's all about. So we're looking forward to seeing you guys. If you guys want to attend, there's still a few slots left. Principlesofprogramdesign.com. We'd love to see you there. And also, too, we're actually working with a couple gyms as well, where we're going to be doing some private events for gyms. We're going to go in and work with their staff. So if that's something that you're looking into, maybe you want to bring us in and we can teach you about this whole entire system and do a closed course, we can absolutely help you out with that. And feel free to send us a DM as well. So hope to see you soon. And I got to give a shout out. Saturday night, my main man, Rob Font, who's been my client for 10 years, is going to be headlining the UFC card on Saturday night. So big props to my buddy Rob, and we can go from there. So we appreciate you guys. We're going to go ahead and share this in a few minutes. Eric, anything else you want to add?
No, I guess the best way we could sum up the course, if you want to know what it's about, again, it's not about, reps and sets and all that stuff. That's a part of it, obviously. But we did 2 beta tests with some of our best friends in the industry that came out back last fall. And almost every single attendee to a person, if we can have you walk away from the course saying one thing, holy shit, I never thought of that, then we won, right?
Yeah.
That's and so you'll be better for it the next day. That's really our goal of all of it. So hopefully you can join us. And I'm looking forward to seeing you down in coming down Jersey way.
All right, sounds good.
Saturday,
All right, appreciate
Saturday
you guys. And once we get this live, if you know anybody that's going to be interested on this talk, please share it with them and tag them as well. And we'll talk to you guys soon.